Oh, go ahead, ma'am.
Hello all, I'm Dr. Aruna, fertility consultant, clinical head of Oasis Fertility, Uppal Center, Hyderabad. Lot of patients they come to us either for second opinion or having had a cycle with us. Those who have had one cycle of IVF and they have failed in that cycle. So the question which looms large on their in their minds and their psyche is that we have not become pregnant and we have completed the cycle. Now, what lies ahead of us? So today we will discuss what can be done for in this kind of situations. So just because we have failed in one IVF cycle doesn't mean it's you have hit a roadblock and that is the end of the journey. It's never like that. Lot of people take more than one cycle of IVF, multiple cycles of IVF to become pregnant. So let us discuss what all it takes for a successful pregnancy to happen, and then let us find out what had gone wrong in the last treatment cycle and what could be done to change the course of the events which had occurred the last time. Is there anything else we can do to better the result in the future fertility plans? So whenever you see that the outcome has not been good in the last cycle, what we usually see is that what went wrong in that cycle or what could have been better in that cycle. Starting with the basic patient profiles, we check their age, what is the any underlying major issues, medical issues are there, how is their lifestyle, anything can be done to improve their lifestyles. Is there anything in their lifestyle which has contributed to the poor quality of their eggs or their sperms? Hmm. So, normalizing, bringing the BMI towards a more acceptable BMI values. Less, least should aim for less than minimum, at least less than 30, preferably around 25, 26 would be a good BMI to start with. So overnight you cannot reduce weight and drastically reduce your BMI, but the aim should be your tomorrow should be better than today. So every day in small increments, work towards bringing the BMI towards the more and more uh, better brackets between 25 to 30. That would be an ideal. So, also it has been found many times that even though there may not be any actual weight reductions visible, but also the physical exercise does tend to improve the hormonal milieu of the patients, making them uh, better responsive to the treatments they are receiving. It also improves their mental status, as in their depression levels. They tend to improve. They are more positive in their approach because of these exercise and physical activities, and also meditation. All deep meditation, mindfulness, or doing these activities. So this will improve the. It will try to um, take back the body systems towards a restorative actions take place, and they try to rectify them at the cellular and molecular levels. So everybody should aspire to get back into the right track, normalize their weights, normalize their BMIs, and improve. Generally, they should be they should tune themselves and not lose hope and be optimistic. And when they're tuning themselves in the right directions, they are more responsive to the suggestions we give. The body also responds better to the medicines which we are giving. So, if any, so this will be the starting point. So any lifestyle changes which need any lifestyle factors which need to be fixed should be again re-looked into and try to bring them back to the uh, an acceptable levels. The same, it also includes any substance abuse if you have indulged, maybe not reported to the physician, or like it's a period of self introspection. So whatever, say, like for example, staying late nights or having a very stressful atmosphere at home or office, or indulging in this substance abuse, alcohol, smoking, and other types. All these things you do introspection. Nobody will be looking after you and watching over you. So you are your best friend. You are your best help. So try to lead. Try to cajole yourself into a good, healthy lifestyle. So while you are on these things, we shall be looking into the specifics of the last treatment cycle. For example, what medications you have taken, how much doses of injections you have taken, how did the ovary respond to the medicines you have taken, whether it is only the problem with the numbers or were they sufficient or not, what was the ovary reserve in the first place, what is the quality of the eggs which have been retrieved, was there any issue with the fertilization of the eggs? And before that, what were the semen parameters? Anything could have been done to improve the quality of the semen? And second is, could we have used other techniques for better sperm selection? So these are all the things we would like to again have a relook and see where we can help the couple. So, in this endeavor, maybe when the next cycle we are planning any stimulations for this, maybe we can choose a different molecule than the one which you have already used, and maybe the molecular specifics of the different preparations, the follicles may be able to respond in a better way. Maybe a dose variation may do the trick and recruit more follicles. Maybe you'll get better follicles. So we look into the dosage as well as the preparation of the medicines which you have taken. All the pharmaceutical names of all this, the drug may be the same, but the way they may have made it, like the specific structure of that molecule, the pH of those molecules, and the way they are sourced from, these may play a very crucial role and may affect the follicle response. So the medicines which we have used in the previous cycle, if they need to be altered or they need to be tailored to the specifics of the ovary response, then that may also help in the following cycles. Also, the timing of trigger and when you are planning the pickup and when you are planning the ICSI. Also, it has to be looked into how many of follicles you have were recruited, how many egg complexes were retrieved, and how many of these were mature eggs. So whether there is any issue with the maturation or the oocytes were mature, but the basic innate quality of the eggs was not good. So this is what we look into. And also, how is the fertilization rate? So all this is as per the egg concern. Similarly, with the sperms also we are looking what was the motility and what was the basic quality of the semen. The morphology also plays a very important role, which sometimes might have been overlooked. And what was the sperm selection techniques which were used to prepare the sperms for ICSI? So these are the things which we again relook into. And in here here comes the quality of the sperm. So here and the outcome of the fertilization is not good, and we have had we didn't get any embryos to transfer. So whether there was a cleavage arrest, whether there was a fertilization failure, or whether the quality of blastocysts or day 5, we have culture till day 5, and the quality of the blast which we got, the embryos which we have got is very poor, that they cannot be freezed or transferred. So these are all the things which we look into and find to see what happened in the lab, and could anything have uh, can anything be better, can anything be done in a different way so as to ensure a better quality of the embryo. Because at the end of the day, the number of embryos you get and the quality of the embryos we get, this only determines what will be the what is the clinical pregnancy rate and the live birth rate. So the more good quality embryos you have, the more are your chances of the better quality of embryo, the better success rate we usually see. Similarly, what happened during the embryo transfer? How was the preparation, lining preparation done? What were the values of the hormones when you started the cycle? What was the values of the hormones when you started the progesterone supplements? And what happened on the day of embryo transfer? And so forth. We try to analyze each and everything and look and see where we can cause an effect so that the results can be altered favorably. So uh, in this relooks and introspection of whatever we see, we do first thing, if the genetic any issues we would like to rule out before we plan for another stimulation. So karyotyping, basic genetic evaluation starts with karyotyping of the couple, and this also is followed by simultaneously we would like to check the quality of the sperm before we go for the next stimulation. So quality of sperm is usually checked by uh, what we call as the DNA fragmentation index. That is the way the sperm genetic material is packaged. Sometimes there may be defects either when it is being produced, that is when the sperm are being formed, and sometimes the defects or the stress may be when during the transit, that is when the sperm are produced and let out in the semen. So in the second scenario, we can still manage this kind of stress by doing sperm retrieval by TISA procedures. But if the high TFI is due to the basic quality of the sperm, then we cannot help much in this aspect. But certainly, we do reduce the further stress during the transit by planning for TISA procedures, or we can also do sperm selections with procedures such as microfluidics, which helps us in picking up in better sperms as it mimics the natural uterine system. So since we cannot alter the quality much, the next best thing would be to choose the best ones available. So microfluidics definitely play a very good role in better sperm selections, and does improve uh, the fertilization rate and the embryo qualities. It has been observed as good as something very similar results are also seen when we are doing teaser sperm retrieval, teasers for sperm retrievals. So these are some of the options which are available for choosing a better sperm for ICSI. Of course, these are just because so many ways of doing the things are there, doesn't mean every person would need it. But yes, basically, before going for a second stimulation, I would definitely like to have the basic karyotyping of the couple done, and basic minimum further workup of the semen, like the DFI, and also any other things in the medical history of the partner, and all these things again we will look and we see if a scanning was not done before a scrotal Doppler, again we may do and check any varicocele or any other things are available which may contribute to the poor quality of the sperm. So again, so basically everything we are checking and rechecking, and then proceeding with the stimulation. So what can be altered, what can be done? Sometimes when the fertilization is not happening, before that, if there is the number of mature oocytes which we are getting, if it is less, then maybe we need to be relook and tweak the trigger injections, the way we give the trigger injections, the dosing as well as the timing, and the timing of the pickup so that we get more mature eggs. Similarly, for fertilization, if any help is required, maybe in the form of uh, oocyte activation using any of the methods available. Sometimes we may go for it, especially when there is fertilization failure is there, or the numbers are very less. So these are some of the ways where we can try, where required only, to improve the outcome of the ICSI. Similarly, again, if it is only an isolated case, you may also need to look at the lab conditions where the XC was done, and was it a good standard lab or not, or anything needs to be peeped into the general overall results of that lab. If it is only an isolated case or individual case, then we need to focus more on the individual parameters which might have contributed to the IVF failure. But if there are multiple cases of IVF failure from the same lab, so definitely I would like to see what has happened in the lab, anything which has contributed to the poor IVF outcome, anything which can be corrected. So the lab also, the general settings of the lab and the specifics of the culture and um, the various things which happen in the lab also need to be checked into. So this is the initial part of the assessment. That is, how are the eggs, how are the sperm, and how are the embryos, what is their quality, and how many we have good quality embryos in hand. So then the next part of the assessment goes towards the second part of the IVF, that is the embryo transfer. So if you have got good number of embryos, what is the quality of the embryos you have got, and which day of the embryo culture you have done the transfer. It is a day 5 transfer, or it is a day 2 or day 3 transfer. So cleavage stage transfers, the cleavage embryos. These embryos, they may be looking morphologically very good, very nice looking pictures you might be seeing, but the potential of this embryo is untested, because only when the gene expression happens, the embryo grows to the day 5 stage. So even though it may be looking good, maybe if the potential is not there, you won't be having a day 5 embryo and pregnancies won't happen. So in these cases, again, we have to see it's a day 3 or a day 5 embryo. So if you have got good quality embryos and still the pregnancy has not occurred, means then we simultaneously we look into the equally important second aspect of embryo transfer, that is the uterus lining, whether how it is uterus lining is being prepared. Again, what are the hormone status at the beginning of the preparation of the uterus, at the time of embryo transfer, on the day of embryo transfer, and also the remaining time when the patient is taking medicines at home. Did she have any fever, any febrile illness during the part of while at home taking these medicines, or any other things which could have contributed to her losing the pregnancy also. So when everything is when you have got the desired embryo, the endometrial thickness has been good, and you have transferred a good quality embryo, then also if the pregnancy, if the your pregnancy test is negative, then what is the thing, the other two things which contribute to a successful pregnancy is a good embryo. Along with it, you need a uterine lining, the endometrium, which is in sync and which is supporting this embryo. So the embryo transfer has to be done in what we call as the window of implantation. So window of implantation in the general population, when we see in around 80 to 90% of the patients, it is false. It is same for all people. But then we have seen many times, especially in the infertile population, that this window of implantation, that is the time of the cycle when the endometrium, the lining of the uterus, is receptive, it is receptive to the embryo, it is able to support it, and it is helping it to thrive there and develop there. This window of implantation, sometimes it shifts. Either the receptivity occurs before the time of transfer. Sometimes it get pushed backwards so that when the embryo is placed, the uterine lining is not ready to receive and support the embryo. So this usually happens in the fresh transfers where where the hormone levels are so very high during the stimulation that the endometrium often goes out of sync with the embryo development, and that is why the pregnancy rates in fresh transfers are always lower than that of the frozen embryo transfers, especially when the hormone levels are high. So this is what we would like to check, whether there is an issue of window of implantation. So it can be checked by what we call as endometrial receptive as array, that is ERA, which is the test we do, wherein we check the molecular pattern of the secretions of the endometrium, and it tells us about the exact sequencing there and whether it is ready to accept the embryo or not. So this window of implantation, either it coincides with the regular accepted window, or sometimes it may be early or late or delayed, or it may come before. So based on this, the next time when you can plan for a personalized embryo transfer based on your ERA analysis. Another thing is that the window of implantation is also okay, embryo is also okay, but due to some unknown factors, the immunological factors, the uterus is not accepting the embryo and rejecting it due to many changes which are happening at a very basic molecular level. And most of these factors which are playing here cannot be quantified by the regular routine tests which are available. So immunologically, sometimes the embryo may be rejected, and therefore the pregnancy doesn't happen. Or maybe there may be early miscarriages, say with less than 5 weeks or 6 weeks. So recurrent implantation failures may be happening. So one of these reasons contributing to these are the immunological factors. So in such cases, most of these are the causes contributing to the unexplained infertility cases. So in such scenarios where we have checked the embryo, the quality, and where we have done the ERA assay, and also we are we are doing a personalized embryo transfer. And in such cases, in spite of that, if there is an implantation failure, we can give immunological assistance to these patients in the form of immunoglobulin injections and various other oral medicines, which help the uterus not to reject the embryo. So these are some of the things which we can do in the subsequent cycles. Again, as I'm saying, all these things are not required for each and every patient. It basically we analyze each and every part, each and every step of the IVF and embryo transfer, and as per that patient's particular conditions and requirements, we can devise a treatment plan. And when we are talking about embryo quality, one thing which should come to our mind is the age of the patient. So age of the patient, when it is crossing 35 years, 38 years, definitely the quality of the embryo, the egg automatically it falls, and the resulting embryos have high risk of aneuploidies. So whenever the age factor is there, and we are having also implantation failures, then we would like to do testing on the embryos, what we call as pre-genetic testing of the embryos, PGTA testing. So these patients can also opt for this pre-genetic testing of these embryos before their embryo transfer, though it is not recommended as a first step. Only we tend to recommend it to patients who are 38 years and above, definitely, and also those who have had recurrent implantation failures. Also, if any hormonal, if in the karyotyping analysis, any any defects or structural rearrangements are observed, then before embryo transfer, we need to do testing on the embryos and find out whether the embryo is normal or there are any issues in it, and take the call whether to transfer that embryo or not. So pre-genetic testing of embryos. Um, Pre-genetic testing of the embryos, then checking for the window of implantation, and giving immunological support to the women when she after the just start of embryo transfer, and the following weeks would be some of the ways where we can help the couple reach their cherished goal of pregnancies. So anyone, any questions? So procedure for IVF failure is this only. IVF failure is a time of we try to stabilize. First, the couple will be emotionally and financially struck, physically very much distressed, and so it's a time of when counseling the patient, stabilizing the patients psychologically and emotionally, as well as physically, and then do a point by point analysis of what had gone wrong, or what could be done in a better way to ensure or a better embryo and a better embryo transfer outcome. So it's not that one size fits all. Every case is unique, just as all the children of a couple, maybe of our parents, are all different, as how siblings are all different. The same way, every sperm and every egg has got a unique and a separate journey, so that what had happened in the past doesn't need to repeat again in the future also. Every journey is unique. Every egg, every sperm, every embryo is unique, and therefore we need to motivate ourselves and prepare for the next journey. So for any help or any further queries or any further information on this topic, what if one cycle of IVF fails, is absolutely no need to lose hope. There are so many avenues now available to help these couples reach their to realize their cherished dream of having children. So you can call on this helpline 7825 850 116. Thank you.